So I wanted to do a video on lung abscesses and haven't got the time to record it because I hadn't found a good recording space. And everywhere where I go, it's always either noisy or the microphone is giving back static and maybe there is some background noise. So I hope there's not so much background noise on this one. So grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at lung abscess. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab your piece of paper, grab your pen, and let's go. So by the end of this lecture, you should be able to understand the etiopathogenesis of lung abscesses, the different clinical presentations of lung abscesses, as well as the approach of a patient that has a lung abscess, inclusive of investigations that we're going to order, what we should interpret from them, and how we're going to be managing these patients. So remember that this is going to be a necrotizing infection that's going to be maybe in the background of a pneumonia in most of the cases. Majority of the cases, they do have some underlying pneumonia that may be there. And there's going to be pus that's filling up inside the lung. So you have this cavitary lesion that is filled up with pus. Remember that abscesses are not the only thing that can cause cavities on the x-ray. I will show you a bunch of differential diagnosis that can be non-infectious but still result in pus formation on the x-ray. Remember that most of these abscesses are going to be happening maybe because there is some aspiration of these oral secretions, especially in a patient that may have gingivitis and a patient with poor oral hygiene. And most of these is going to be predisposed to these patients that have reduced levels of consciousness, so those that have risk of aspiration. It could be in the background of alcohol, recreational drugs, anesthesia, sedatives, or even opiates. And in older patients, those that are unable to handle their secretions, maybe they have a neurological disease. Remember that lung abscesses are very common in individuals that are immunosuppressed, so those that are HIV and AIDS, those that are taking immunosuppressive drugs after an organ transplant. So some causes, like I said, most important, aspiration of oral secretions, most common cause. You could have some endobronchial obstructions like a bronchial carcinoma. You could have some hematogenous seeding. Often this one tends to result in these multiple abscesses in the lung. So maybe it could be suppurative thromboembolism, it could be septic embolism, it could be due to IV drug use or Lemierre's syndrome, or it could be a right-sided endocarditis. So like I said, these ones are going to be presenting generally with multiple abscesses rather than isolated one. Or it could be indeed a direct infection from maybe an empyema or a subphrenic or even a mediastinal abscess, especially those that have Staph aureus. Some implicated pathogens include anaerobic organisms. This is very important to know because when you're targeting or when you're investigating these patients, some antibiotics are going to be working much better than others. So your anaerobic pathogens are going to be coming from aspiration, so things like Peptostreptococcus, Fusobacterium, Prevotella, as well as even bacteroids. Or you could have some aerobic pathogens like Streptococci, Staphylococcus aureus, like the MRSA, the methicillin-resistant Staphylococcus aureus. That's one we're worried about. You could sometimes have some gram-negative bacteria. These tend to be hospital-acquired, like Klebsiella. You can have some in immunocompromised patients like Pseudomonas aeruginosa or even some gram-negative bacilli, but you can also have things like Nocardia and Mycobacterium as well as fungi. Remember that in some rare cases, it may actually progress and lead to this extensive necrosis of the lobe of the lung, sometimes even an entire lung. You can lose an entire lung. They can develop pulmonary gangrene, or they can develop a fulminant pneumonia. This tends to be seen with pathogens like the MRSA and even with pneumococcus and Klebsiella. Some patients can also have an abscess due to other non-bacterial things like amoebic infections like Entamoeba histolytica. It could be hydatidic cysts. It could be paragonomyiasis or infections with other pathogens. Even Mycobacterium can actually be implicated. Now, what exactly is happening? This person gets an infection in their lungs. So they'll have similar features to a pneumonia, actually. They'll have this inflammation that is taking place that can be about 1 week or so. Eventually, this is going to lead to necrosis of the tissues, and then eventually the abscess is going to form. And sometimes the abscess can rupture into the bronchus, and then this person will expectorate. So they'll have this productive cough, sometimes which may be associated with foul-smelling sputum. It may sometimes be blood-stained. So it will leave behind this air fluid level cavity that you can actually see on the X-ray. In about 10% of the cases, they may have direct or indirect extension. So maybe they have a bronchopleural fistula into the pleural cavity, and they may also have an empyema that may be there and may need to be drained. So clinical features depend largely on the organism that is affecting you. The anaerobic organisms, or if you have a mixed anaerobic and aerobic organisms, these ones have an insidious course. So generally, they're going to be taking about weeks or months. They'll have this productive cough, fever, night sweats, weight loss. They'll have this occasional hemoptysis. They may sometimes even have pleuritic chest pain. They do have sputum that they're producing, which tends to be quite purulent. Sometimes it's blood streaked, and generally it's going to be classically quite smelly, and it will even taste quite foul. So they'll have a fetid and a putrid type of breath. They'll have very, very nasty breath. Then in terms of the aerobic bacteria, these ones tend to have acute symptoms. They tend to resemble a bacterial pneumonia. For those that do have anaerobic organisms like Mycobacterium and Nocardia, they don't have the putrid respiratory secretions, and they're more likely to have this occurring in these non-dependent regions of the lungs. In terms of the physical examination, they may be non-specific features. So they'll have features that resemble a pneumonia. So they may have decreased breath sounds that may point you to either a consolidation or an effusion. They have a temperature that's greater than 38. They'll have crackles if you auscultate over the area that is affected. Agophony, sometimes downness to percussion if they do have a pleural effusion. Some signs of periodontal disease may sometimes be present. Sometimes you may get some history of predisposing causes of aspiration. For example, they took alcohol, or they were found unconscious, or maybe anything that is affecting their swallowing. They have some sort of dysphagia. In terms of the diagnosis, some investigations that would order a chest x-ray. Often a CT is better if you want to visualize and if you're suspecting that there's an endobronchial obstruction. Sputum cultures for aerobic bacteria, for fungi, as well as the mycobacterium. You can do a bronchoscopy to rule out any cancers, and you'll be able to even sometimes pick up these unusual pathogens like fungi, the mycobacterium, especially in the immunocompromised. You should aim to do a bronchoscopy. Then culture can also be done on the pleural fluid. In terms of the x-ray, you're going to see, of course, this cavitary lesion that's going to be having the fluid air levels. And generally, in these anaerobic infections that are going to be due to the aspiration, generally your chest x-ray is going to show this consolidation with a single cavity that's going to be containing air fluid levels, and even in portions of the lung that would be dependent, especially when the patient is actually recumbent. So remember that the posterior segments of the upper lobe or the superior and lateral basal segments of the lower lobe, that's where you're going to be seeing these things. Generally, in this pattern is actually going to help you to distinguish anaerobic abscesses from other causes of cavitary pulmonary disease. And because, for example, if you have diffuse or embolic pulmonary disease, often it's going to be causing these multiple cavitations as opposed to one cavity. And remember, in TB, you're going to see the cavities generally in the apices of the lungs. So here's a picture of a pleural, pulmonary, and even a bronchial infection. As we can see here, there's this mass that we can see, this cavity that we can see that even has this air fluid levels in them. It's quite huge type of lung abscess here. Some lesions that may cause cavities on the x-rays that are not necessarily infections. It could be things like empyema or bullae with air fluid levels, cystic bronchiectasis, lung cancer, lung infarction, pulmonary embolism, nodular silicosis, nodule with central necrosis, pulmonary sequestration. It could be sarcoidosis, granulomatosis with polyangiitis. You could also have it in rheumatoid lung nodules. A CT scan is rarely needed, but generally, if the cavitation is clear on the chest x-ray in a patient who has these risk factors and your high index of suspicion that it's a lung abscess, no need for you to get a CT. But it can be actually useful when you're not so sure on the x-ray and you're maybe suspecting that there could be an underlying pulmonary mass, and that may be obstructing the drainage of the lung segment that is suspected, and you can do a CT scan. And when the abscess needs to be differentiated from empyema or a bullae with air fluid levels, you can do a CT scan. In some cases, when you're suspecting a bronchial carcinoma, aim to do a bronchoscopy, especially in those patients that are immunosuppressed. Generally, this can lead to The bronchial carcinomas can lead to this obstruction that can cause pneumonia and can lead to abscess formation. Generally, if you're suspecting this, you should suspect it in patients that you suspect to have a lung abscess. You start them on antimicrobial treatment. Generally, they're not responding to this treatment, or they have this atypical findings and you see cavitary lesion, but they don't have fever. So generally, do a bronchoscopy. You're going to exclude the cancer or the presence of any foreign bodies or detect any unusual pathogens like fungi and mycobacterium. In terms of the cultures, the anaerobics are actually rarely identified on the culture because the uncontaminated specimen are quite difficult for you to get, because most laboratories are actually not going to culture the anaerobes quite well. If the sputum is actually putrid, then we should assume that there is an anaerobic infection. If the empyema is present, then the pleural fluid can actually be a good source for you to culture these anaerobic organisms. And then generally, when you have these clinical findings that make anaerobic infections less likely, then you should think of things like anaerobes, fungi, mycobacterium. You should suspect those things and you should try and identify those pathogens. So cultures of the sputum, the bronchoscopic aspirations, or sometimes even both can be helpful. In terms of management, you want to put them on antibiotics. For those that are less seriously ill, oral antibiotics. For those that are ill, IV antibiotics. You want to drain the abscess in some cases, especially those that are not responding to therapy. So sometimes we may perform percutaneous, sometimes endobronchial, sometimes surgical drainage. In terms of our primary choice of antibiotics, we want to use a beta-lactam combined with a beta-lactamase inhibitor. For example, ampicillin and sulbactam combination, 1.5 grams to about 3 grams, IV or IM every 6 hours, and the dose should not exceed 12 grams per day. Or alternatively, we could use carbapenem, that's imipenem and cilastatin. That's about 500 milligrams IV every 6 hours, or a combination therapy with metronidazole, 500 milligrams 3 times a day, plus a penicillin, 2 million units IV every 6 hours. For those that do have penicillin allergies, we can consider clindamycin, 600 milligrams IV every 8 hours, moxifloxacin, 400 milligrams once a day, or a combination of levofloxacin, 750 once a day with metronidazole 500 every 8 hours. Remember that once they become afebrile, we can actually convert the IV regimen to the oral regimens. For those that are less ill, you can cover them on oral antibiotics, the amoxicillin and clavulanic acid, 1 gram orally every 12 hours. Those that have a penicillin allergy, you can use clindamycin 300 milligrams orally every 6 hours. Then those that you do suspect MRSA, you can use linezolid and vancomycin. If you are suspecting a gram-negative bacilli and you culture it in actually significant concentrations from the sputum or from the blood, then you identify it by your gram stain, then you should cover them on something that is going to be targeting these gram-negative bacilli. So generally, your clindamycin 600 milligrams IV every 6 to 8 hours is a good choice, though it's going to have this activity against the streptococci and the anaerobic organisms. However, it becomes actually a second-line drug because there is actually cause for concern of the Clostridioides difficile, which was previously referred to as Clostridium difficile. I think it was renamed, and you can get this type of infection, especially for those that are on antibiotics for a very long time. You tend to actually promote growth of certain organisms. So actually, it is still quite useful as a choice for those that have a penicillin allergy. In terms of the duration, generally there is no consensus as to what is the optimum duration to treat a lung abscess. But commonly what I've seen being done is that we look at the x-rays. You'll be taking serial x-rays. You give the antibiotics until there's complete resolution of the abscess, or you see a small stable residual scar. Generally, this may take about 3 to 6 weeks or sometimes longer. So if you have a bigger abscess, it's going to take a much longer time to resolve on the x-ray. Most authorities actually don't recommend that you should offer some physical therapy or postural drainage, because generally this may foster any spillage of the infection into the other bronchi, and extension of the infection potentially can also cause acute obstruction. There is some role of surgical intervention, especially if they have an empyema. It must be drained. Sometimes we do perform some surgical removal or drainage of the lung abscess, especially in about 10% of the patients that are not going to be responding to antibiotics and those that develop pulmonary gangrene. For those that have resistant to antibiotics, it's quite common if they have large cavities and those that have post-obstructive abscesses. So generally, if your patients are not afebrile by about day 7 to day 10, then generally you should suspect whether you have a resistant organism, or you have something that is unusual, or there's an airway obstruction, or maybe this is a non-infectious cause. So generally, surgery when needed, you can perform a lobectomy, which is the most common procedure. where there's surgical resection, sometimes which may suffice for the smaller lesions. Those are less than 6 centimeters in diameter. Sometimes a pneumonectomy can be done if you have multiple abscesses that are not responding to drug therapy, or if they have pulmonary gangrene. In your patients that are likely to have a difficult surgery, or they are likely not to tolerate surgery quite well, you can perform percutaneous drainage, or rarely bronchoscopy placement under the ultrasound guidance of a pigtail catheter can sometimes be done to help with the drainage. I really hope you enjoyed this video on lung abscess. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.